I'm going to give you a perspective from the National Institute for Health Research. I arrived there on the 1st of April, so I'm still the new kid on the block. Although for the previous 10 years, I was involved with an organisation called National Voices, a charity that promotes patient and public involvement in health services, more emphasis on services than research, but obviously many of the issues are the same. So I've been used to taking a kind of patient-centred view on things for a number of years, and that's my background. So next slide, please. Just a little bit of context. Some of this may be familiar to you already. I don't know what the state of knowledge is about the NIHR. It was founded in 2006, and it's essentially an arm's length organisational system supported by the UK government to undertake and support and commission research in health and social care and public health. And it is in fact the largest UK funder of health and care research. And right from the beginning, it has had a commitment to involving patients and the public in the work that it does, with the express purpose of making the research better and more impactful. And so some of the activity that we have done over the years will be familiar to you under the banner of NIHR Involve. From the 1st of April, there was a sort of modest reorganisation of some of the functions within NIHR. So the focus on involvement, which was under NIHR Involve, and that on disseminating evidence, were brought together into a single centre, the Centre for Engagement and Dissemination, which is the one that I am the director of. I also have a cross-cutting role within NIHR to bring the voice of the public into the work of NIHR and to ensure that that is heard with impact. I'm still working out how to do that, as I'm the new kid on the block, watch this space. So next slide, please. Some of the ways in which the terrible COVID-19 pandemic has impacted on our lives and on health and care research have already been prefigured by Gary in his introduction. In the context of NIHR, which oversees a portfolio of research in which more than £1 billion of taxpayers' money is spent a year, much of that research was put on pause for the pandemic, and meanwhile lots of effort was put into commissioning new research that happened quite fast and with new processes. Lockdown and the pandemic actually created vastly new conditions for undertaking engagement with patients and the public, not least because people couldn't leave their homes, because many people were self-isolating or shielding, and because much previous activity was on pause. One of the other things that I think happened was that when people were thinking about how do we engage the public, the question about how do we find participants to take part in trials for vaccines and treatments loomed very large, possibly to the exclusion of some of the other considerations about working in partnership with people. So there are some of the ways in which, largely unavoidably, I think, that the pandemic has impacted on the way in which patient and public involvement is done. So that's kind of like the context setting. Could I have the next slide, please? What have we learned in the couple of months, certainly since I arrived on the scene, which isn't a long time? There has been evidence of decline in the commitment to and the ability to carry out engagement. Some of this evidence comes from people reporting back their own experiences, and in fact the poll we did right at the beginning is a good example of that. The starkest piece of evidence that we came across was from the Health Research Authority that provides ethics approval to new research projects, and they found that whereas in normal times the studies that come to them for approval, something like 3/4 of them have plans and commitments relating to patient and public involvement. That had gone right down, gone down to about 20%. But we also heard other evidence about really good engagement, and it seemed to be a very mixed picture. One of the features of where engagement seemed to be working well, despite COVID, was where researchers already had existing relationships and networks with public contributors, where there was an existing ecosystem of engagement, it was possible to draw upon that. Where researchers were starting from scratch, they didn't have people to draw upon and often felt they didn't have the time or the ability or the confidence to go out and do public engagement. Of course, the pandemic has highlighted and possibly even accentuated existing inequalities. So the very people who have been most affected by the disease are also those who are most likely not to be involved in any meaningful way in health and care research. These were conditions that applied before the pandemic, but I think they've been accentuated by them. At the same time, lockdown, I think, has changed, whether in the context of patient and public engagement or more generally in life. I think we've all found that what it is possible to do online has our understanding of that has expanded. Things we thought were difficult or impossible or a pain or not worth bothering with have turned out to work quite well, or at least partially well. So we've had to rethink digital engagement. The other thing that we've become very aware of is that at the same time as people were saying PPI has taken a knock and the national leadership bodies should be doing something about that, lots of people were getting on and doing things anyway. So we've come across a lot of examples of spontaneous organising, people getting together, researchers, patient and public engagement leads, public contributors, members of communities getting together and spontaneously trying to do something about engagement in COVID. And my next slide just gives one example of one of many that I've come across of a local initiative, in this case a bunch of people in the southwest of England, the Southwest Academic Health Science Network, bringing together researchers and academics and public contributors to work out how to do co-production in the context of COVID. And I think we should celebrate that spontaneous organising at local level and grassroots level, and perhaps have a discussion about what could be done to support and encourage that. So my next slide, please. NIHR was acutely aware that we needed to do something to respond to concerns about the potential sidelining of PPI during COVID. One thing we did quite early on in the life of the News Centre and involving the PPI leads across NIHR was to publicly reaffirm the NIHR collective corporate commitment to patient and public involvement. I'll say a bit more about that in the next slide. We collaborated in various ways with a number of other national leadership organisations in the public sector and charity sector. Various workshops and meetings were held. One of the initiatives that Gary's already referred to, the Health Research Authority, creating a matching service, bringing together researchers and available public contributors so that researchers who needed to engage people would be able to find and involve people in their COVID-related studies. And I think that's a fantastic initiative, which probably we ought to have got around to doing a long time ago, but which builds the connectivity between the research community and communities. The other thing we had to do internally within NIHR was to make sure that all the strategic decision-making processes about the creation and management of a pipeline of COVID studies, but then also the management of restarting those studies that have been on hold, which is now underway, that there was proper public voice and public contribution to that strategic decision making too. So while PPI is really important at the level of the individual study and research program, does also need to be reflected in the decision making of national bodies. It took a bit of work to get that right, actually, and we may not have got it totally right yet. But it's a good example of where public engagement needs to thread all the way from the local to the national. So my next slide gives you is just a graphic summarising the UK standards for public involvement. These were developed in a collaborative process involving NIHR and many other partners, and they were published last year. And these are excellent standards, and there's a whole work stream now around trying to put them into practice. But the public statement that we made on the 17th of April was to say NIHR remains committed to patient and public involvement in research in all its manifestations, and that the way we will seek to do that is in accordance with the standards that we help to develop. So making sure that opportunities are communicated well, that we collaborate as a health and care system and with communities, that we make the opportunities for involvement as inclusive as possible and as diverse as possible, that we focus on achieving impact, not just having activity for the sake of activity, that we embed involvement into the governance and decision-making processes of research, and that we do everything to support people to learn from their experiences and build a body of knowledge about what works well. So that's a very, very brief summary of the standards, but we wanted to make sure that we were committing internally across NIHR to continue to embed those standards in the very different context of COVID-19. So I think this may be my final slide coming up, or towards the end. Yes, I think this may be the last one. So some reflections about COVID, patient and public involvement, and what the implications might be as we try and get back to some kind of normal. So in NIHR, we are now implementing what's called the Restart Implementation Program, which is starting to take off the back burner of the large amounts of research that had to be paused during the pandemic. And my view is that the restart is also an opportunity to refresh our thinking about how we do patient and public involvement and how we embed the standards. I think one reflection is that COVID-19, bluntly, has maybe pricked a little bit of complacency. Maybe public engagement and PPI were not as embedded as we thought they were. If they could so easily be sidelined because people feel they don't have the time or they don't have access to the right people, then maybe we haven't quite got it embedded well enough. So as we return to whatever the new normal is going to be, I think we do want to take time to have some fresh thinking and some fresh determination to make things really good and to learn from the COVID experience. Where there are frontiers that we still need to push at, I think one of them is about really embedding public engagement as a key research discipline, not just something that has to be done because there's a compliance requirement, not just something that has to be done because it's the right thing to do morally, but because actually it's a key part of the way people do research. And I'm not sure it's quite embedded in that way in all health research yet. How to find people to engage and involve in research. The HRA initiative to connect researchers to public contributors has taught us a bit of a lesson, I think, about the need to have what I would call an ecosystem of relationships. I think a lot of effort on PPI research is often focused on getting the involvement in a particular study. Finding bodies for studies, that's my terminology and my made-up term, not anybody else's. But rather than finding bodies for studies, maybe we should be developing ecosystems of relationships between communities and research enterprises that are long-lasting, that evolve, that are sustainable, and therefore more resilient to shocks and changes such as the COVID-19 pandemic. We do need to, I think, get more serious about how we ensure that everybody has the opportunity to be involved in research, not just white middle-class professional people, but people from all the diverse communities that live in the UK, and particularly those who have most to gain from taking part in research because they may have most at stake and be most at risk. We certainly haven't got that right yet in the UK, and there's more to do. Digital engagement, as I say, we've all been on a learning curve, and maybe we can think differently about how we can both get more diverse and inclusive and make better use of digital. To some extent, there's a bit of a tension between those two things, but there need not necessarily be. I think we should push at both frontiers. Lots of local initiative, as I was saying. How can national bodies do more to support and enable local initiative, or maybe just get out of the way of it rather than duplicating or muddying the waters? There's a whole pre-existing dynamic. It's a subject of another workshop in itself about getting the right balance between national and local, but that I think is an important one in the context of PPI. My watchwords coming into this job are looking at the complexity of the arrangements involving patients and the public in health and care research. Is, can we make it simpler for everybody, make it simpler for researchers, make it simpler for members of the community to get involved? Can we make it absolutely a normal part of research, not just a kind of add-on? And can we make it universal in the sense that everybody has the opportunity, regardless of their race, gender, or any other demographic characteristics? So those are some reflections on what we should be doing next in the light of what we've learned from COVID. I think my final slide is just contact details and Twitter handles. Thank you for listening.